Okay, I'll make that 12:30, so I'll start proceedings. Good afternoon, everyone. My name's James Thornton. I'm the Senior Communications Manager at the Healthy London Partnership, HLP. Thanks so much for joining us today in the second of what's now become a three-part series in primary care and homeless health in reaction to COVID. I shall do the housekeeping first, so please do make sure you're on mute. Please make sure your camera is turned off. We will do Q&A at the end, but do put your questions in the chat box as we go along, and that will help get our grey matter going as we head along. We will endeavour to answer all of your questions, and if we can't answer them today, we'll take those away and we will come back to each of you if there's not an answer we can have ready to hand. We're joined by two eminent speakers today. I'm really looking forward to this session. So with us, we've got Sharon Clint, who's our Learning and Development Manager from Groundswell in Sharon. And we've got Dr. Jasmin Malik, who's Clinical Lead for Homeless Health at NHS North Central London CCG. I'll let them do proper introductions to themselves in a moment. I think if you joined us on Monday, and if you didn't, the recording's now available on the HLP website. I think you'd have got a fantastic background in the whole homeless situation itself and some great preparedness for helping people have the best experience in primary care, and a lot of what's happened in terms of the COVID responses. And just another reminder to switch off cameras and go on mute while I'm here. Today we've got a lot of that. We've got a lot of necessary reiterating some of those strong messages, but I think what we've also got is a fantastic journey, if I can't overuse that phrase, sort of for the patient before, during and after interaction with primary care. So on that note, I will hand over to our experts and then I'll rejoin you for Q&A at the end. And as I say, please do pop your questions in the chat box and we'll pick them up at the end. Jasmin, I think I'm handing across to you.
Hi, thank you, James. Thanks for that introduction, and hello and welcome everybody. Thank you for joining us today. So I'm Jasmin Malik. I'm a GP at Camden Health Improvement Practice and clinical lead at North Central London for Homeless Healthcare. I've been working in this area for about 5 years now, and myself and Sharon have done several education events tailored specifically more around general practice and how to sort of address healthcare for those who are homeless and helping them engage with services. I'll hand over to Sharon.
Thank you very much, Jasmin. So my name is Sharon Clint and I am the Learning and Development Manager for Groundswell. Groundswell's a small to medium-sized charitable organisation supporting homeless people to get to health appointments, and we do this through utilising people with lived experience, using them as volunteers, training them up as peer advocates and sending them out to physically support people to get to those appointments and support them in any other areas that they need around their healthcare.
Great, thanks. So I'm going to start sharing the slides now, so that just so in terms of, like James was saying, this is a second part of a three-part series, and I'll just give you a quick overview with regards to webinar 1, if people didn't manage to make that webinar. In terms of what they covered at that time was them expressing about how people experiencing homelessness have a significant rate of multimorbidity, substance misuse and mental health difficulties, and that often there is association with significant complex traumas. In that webinar as well, they outlined the average age of death of people who were rough sleeping being in their 40s, as well as there being early onset aging and frailty quite prevalent. Due to the various complexities of need, a person-centred and holistic approach is really encouraged to help engaging people and developing trusting relationships. They outlined there as well about the response to COVID-19 and the pandemic, and how people who were rough sleeping and in shared accommodation have been moved into hotels. Outlining again as well that 30 to 40% of this population fall into the category that require shielding, and due to the vulnerability will require shielding going forward. They also did an overview of housing law and Homelessness Reduction Act, as well as discussing ways to assist people with no recourse to public funds. So today, in today's talk, we're going to address a couple of the misconceptions around homelessness and talk as well as James was saying, about a journey through the practice, using a couple of case examples in terms of how to look at addressing barriers to healthcare, trauma and mental health within homelessness, also looking at wound care specifically, and further addressing the person-centred care. I'm going to use the opportunity to talk again about COVID-19 and homelessness, but also specifically looking at how primary care has the opportunity now to help maintain and build on the health gains from these people being in hotels. And I'll finish off with some matters with regards to safeguarding. So I'll hand over to Sharon to talk a bit about Groundswell and give us a bit of background there.
Thank you, Jasmin. Yes, so as I said, Groundswell is a small to medium-sized charity, and we've been around since 1996, supporting homeless people to be involved in the delivery of solutions to homelessness. This would include our peer research, our client involvement, and tackling health inequalities associated with the experience of homelessness. So we have a vision, and that vision is of an equal and inclusive society where solutions to homelessness come from the direct experiences of those people experiencing homelessness. And our mission, well, we exist to enable people who are homeless to create solutions to move themselves out of homelessness, and to this benefits our whole society. Next slide, please. Thank you.
I'm trying to do so. Okay. There we go. Okay.
Thank you. So today I want to focus a little bit on some of the homeless misconceptions, and there are many, but I picked out a few of the favourites, and I use that word liberally. So homelessness is a choice. That some people choose to be homeless, and that it's a life choice that they're making. As somebody with lived experience myself, I have been saying for a very long time that I feel that homelessness in itself should constitute some form of safeguarding alert, which it doesn't at this present time. But by the very nature of somebody choosing to be homeless, if they say that that's their choice, I feel that that in itself creates concern for me. I don't think anybody with their right mind would choose homelessness as a life choice. People become homeless due to a lack of education. Well, as somebody who's managed volunteers in the homelessness sector and worked with people in the homelessness sector for the past 10 years plus, I can categorically state some of the volunteers we have coming to us at Groundswell. We've had people who have been lawyers historically. We've had doctors come to us who have fallen on hard times and found themselves homeless. People become homeless for many, many reasons. Lack of education is by far not one of them. Those who find themselves homeless are simply lazy. It may look like a lazy existence, but again, speaking from experience and speaking from not just my own personal experience, but from the stories I've heard throughout my lifetime, it's a very hard life. You have to be very proactive to maintain your life, to survive homelessness. If I consider now, I'm probably more lazy now as a person indoors than I ever was outdoors, with the access to internet banking and online shopping. So no, not lazy. And all homeless are drug addicts. Well, it's true that there are people that are utilising drugs and using alcohol to excess, but by far it's not the norm. There are a large number of homeless people who would never consider using drugs or alcohol. And just to highlight that point, a recent study by Groundswell showed that at the time of interview, 58% of people that we interviewed stated substance misuse issues, and 53% of those stated that they were suffering from chronic pain. So it may be fair to say that some of those people are self-medicating to try and get away from that pain. So we're going to, across the course of this webinar, we're going to talk to you about Betty and Alf's journey throughout the practice. So I'd like to introduce you to Betty, and this is Betty. And Betty's come into your surgery today. She's very new to the area. and isn't yet registered with you. She's carrying her sleeping bag. We suspect she's rough sleeping, doesn't smell very good, and is presenting as possibly being on substances. So I want to talk very quickly about some of the barriers to accessing healthcare for the homeless population. So first and foremost, health is not seen as a priority. I just want to tell you very quickly, Groundswell, when we started out, we were a very shouty organisation way back in the day, creating these big events where we brought homeless people, service providers and game changers into the room. So we have MPs like Mo Molam join us at some of these events, and they'd be very shouty, as I said, with homeless people going, why can't you sort this out? And service providers going, well, we haven't got the money, and game changers going, well, we don't know where to find the money. And so loads of stuff came out from that. And what Groundswell picked up was one of the things that nobody was prioritising was health, physical health specifically at that time. So we had a lot of organisations dealing with housing or benefits, but nobody was working around physical health. So we decided to do that, and we hope to do it well. But when I say health is not seen as a priority, even homeless people are not prioritising their physical health. There's a difficulty building trusting relationships. I think that speaks for itself. There's a feeling of being unwelcome. Historically, homeless people experiencing homelessness may attend somewhere if there's a vast group of other people, if they're walking into normal society, let's say, excuse the concept. If people are finding themselves ousted from that society, if they're walking into large groups of people and having people turn their nose up at them or treat them differently, then they're feeling very unwelcome. And as that builds, that just becomes an overwhelming, this is how it is. A fear of withdrawing. So this really, a fear of not being listened to. That would potentially, I have an experience of going to a doctor's surgery with an ailment, and one of the first set questions to be asked was, well, how many cigarettes do you smoke a day? Are you drinking? How much? Are you using? Do you inject? And it's like, I understand that these questions are very important, but if we could focus on my ailment, I'd really appreciate that. The fear of withdrawing, this would come from more going into hospitals, so people not wanting to have those stays in hospitals because they're fearful that once they get admitted, any script they're on, maybe the timings of that's not going to come about quick enough for them, or if they're needing alcohol to mobilise, how they're going to be able to maintain that time in hospital without that crutch. Inflexibility, appointment systems and lack of joined up care. So appointment systems recognisably across the board can be very inflexible, but equally a lack of joined up care where maybe I have multiple things that I need to see a doctor for and they're scattered across the board. And challenges within the registering with the GP. Before we quickly move on, I just want to quickly touch on the fact that there's a fear of the unknown. Often clients may sit on an illness because they don't know what's wrong with them and they're a little bit scared about what that might be, and they may not actually want to hear the results of that. People with mobility issues, and this links in very clearly with cash flow problems as well. If people have mobility issues and can't make it across town to get to that appointment without a taxi, but then don't have the money to get the taxi. Memory issues. We have a lot of our clients are suffering for whatever reason with memory issues and simply may not remember that they have appointments coming up. And the whole online website thing, which we're going to see a lot more of. We're going to see a lot more of this digital divide, people not being able to access services because everything's going online. So when we speak about online, I did go online and do a little bit of research because one of the major barriers our client group has to accessing appropriate healthcare is the need to be able to provide evidence of who they are and the need to provide evidence of where they live, which many people, either by never having had identification or having had it stolen or lost through the transient nature of their lifestyle, equally not being able to provide evidence of where they live because they have nowhere to live. So I went online and found a lot of evidence to suggest that these all need to be provided. I did find this one website, this one surgery that almost gets it. You'll note that I've underlined rough sleepers identity badge. I've done a bit of research and I can't actually pinpoint what that is. I've never heard of that before. But somebody does at least recognise that there are rough sleepers, and they obviously may access the surgery, as well as as long as they provide evidence from Section 2 as well, so their latest council tax letter or a utility bill, which they're very unlikely to have either of. So what we really want to see more of is the other side of this page. There is no need to provide other documentation. You do not need to show any ID or proof of address to register. This is the ideal, because in truth, nobody needs to prove who they are, nor do they need an address to be able to register with a GP. So we also have communication. Communication is a major barrier, and a lot of people do struggle with communication, and I think that goes across the board. I don't think that's significantly just a homeless problem, but within homelessness, some of the things to be aware of as to why somebody might be struggling to communicate, or why you might be struggling to communicate with them. So if they're hard of hearing, if there are language barriers, being forced to repeat oneself, no, truthfully, on that point, homeless people are asked to repeat their story over and over and over. I was asked in the period of about 3 months to give my 5-year housing history, and at that time I'd been homeless for 6 years, so it was quite vast and it took a long time. There needs to be some joined up thinking. Feeling disempowered and a power imbalance, please remember that no matter what area of your surgery you work in, when you are faced with the client, you have all the power. Confusion, being tired, hungry, in pain or discomfort, and an inability to express what's going on for them. Embarrassment or fear, that's a big one. Learning difficulties, brain injuries, drug and alcohol causing difficulty, not feeling heard. We've heard many times clients coming and saying, I went in with a specific problem and I just feel like I never quite got the message across. Not having what they feel is important addressed, as I mentioned earlier. And an expectation of being treated less than. So if every experience a person experiencing homelessness has that negative connotation of you're not part of this society, then they just expect to be treated that way and will probably play out. Please note that many people experiencing homelessness may use bad language. They may become loud and animated in trying to express themselves. They may use the F word. Please note they may be swearing, but most likely they're not swearing at you.
Thanks. And coming off the back of that, so it's really quite important in terms of this diverse group of people who are facing homelessness. There's a poorer physical and mental health than in the general population, leading to premature death. And one of the major barriers is that they're also dealing with varying degrees of trauma and long-standing history of not being able to engage. It's important to understand so that mental ill health is strongly associated with homelessness as both a cause and a consequence. And not only do people who are experiencing homelessness find themselves there because of trauma, but they're also experiencing being homeless brings traumas on repeatedly on everyday basis. In terms of the different types of mental health associated with those who often find themselves homeless, you have a high prevalence of depression, affective disorders, psychotic disorders being 15 times more prevalent than in the general population, histories of substance abuse and personality disorders. In terms of personality disorders, about 70% of that population could potentially fit into the criteria of personality disorders. And the stigma associated with that is really quite high. And if you're carrying the diagnosis of the core of who you are is considered disordered, when actually basically you've formulated certain types of behaviours and certain types of patterns that have helped you survive the various traumas that you've experienced throughout your life, it's really quite hard to carry a diagnosis of that personality disorder. As you'll be aware, there'll be a range of different challenging presentations, from fits of potential anger, fear-based sort of responses, and also within the consultation you might find that they're breaking down and in tears, and everything. You may experience that there's anger and crying and different emotions throughout the consultation. One of the other areas is to bear in mind, like Sharon was saying, it's not always associated with drug and alcohol use within the homeless population, but there is a significant proportion that do have this dual diagnosis, and co-occurring mental health and alcohol and drug use really is an issue for preventing people from accessing healthcare. So in terms of this next slide, this slide was provided by Flick, which is Fulfilling Lives in Islington and Camden. And it takes us through a journey of somebody who has barriers of getting healthcare when they may have underlying diagnosis, undiagnosed mental health or trauma. And it sort of reflects about people sort of turning to substance misuse as a form of self-medication and the various times that they may try and seek help. And bearing in mind that seeking help in itself is a massive thing for somebody to try and sort of explore. And at that point of seeking help, that may sort of trigger certain types of behaviours as a result of previous traumas coming back to the surface. So as a result, causing them to self-medicate and use substances further, which in turn impacts on that engagement with services. So if we don't take a sort of more of a holistic approach or a view from the dual diagnosis perspective, and we're taking sort of mental health separately to that use of substances, then we're really sort of having that big barrier in place in terms of being able to access services. And actually, you'll find that there's obviously the frequent people who are discharged from the service because they're not engaging. So I'd encourage people who are sort of their GPs to get involved with MDTs and services which are linking in the different services that people are involved in. Okay.
Must unmute. So Jasmin, let me ask you a question. So Betty's arrived, she's standing around in reception, she hasn't registered, but she feels she should. What does she need to do? How can we help her today?
Okay, so yeah, in terms of registration, I think we've already addressed quite clearly that we don't have a right really to refuse somebody because they don't have any identification, and that the only real reason that if somebody is not being accepted on the list is because the list is closed or that a specialist service is required. It's also important to remember that it doesn't matter how long somebody's been in a certain catchment area, and regardless of that amount of time, they can be registered. To bear in mind, obviously at this point in time with the situation around COVID, there's a lot of movement of people from different locations, different boroughs, and that it may be necessary just to consider a temporary registration so that the urgent and necessary can be dealt with if people are going to be returning back to their previous GPs. Assistance with registration. So I'd be checking to see if, for example, Betty, if she has anybody who could assist her with the forms, if she has any problems with language, any language barriers, or even if she's able to read. These things that need to be considered and thought about trying to help her with the process of registration. In terms, again, obviously now with the COVID situation, there's going to be much more online and telephone situations. So linking in if they do have key workers to help and assist getting that registration in place. The other aspect is that you could use the care of address as the surgery. And if you are using the surgery as the care of address for receiving healthcare correspondence, just reminding the patients that they can check in every now and again to make sure that they're not missing any of the mail for their appointments, etc.
So, I'd like to introduce you to Alf. Alf has been rough sleeping now for 6 years. This is because his partner died, leaving him with nowhere to live. He does drink, but he wants to give up. The problem is he's currently struggling to mobilise in the mornings without a few cans. He used to be registered at your surgery, but hasn't used your service in about 8 years. and he wants to know if he can speak with the doctor today about his mental health. He says he's starting to feel very low. Now, an appointment has been booked for him. It's in 9 days' time, and it's at 3:40 p.m. So I've got a few questions again, if you don't mind, Jasmin.
Sure.
So Alf is suggesting that, yes, his mental health is low, but he has a few other aches and pains that he would like to discuss, and he's wondering if he can have a little bit more time. He's also suggested that 9 days' time from now is a Wednesday. He gets his benefits on a Wednesday, so he's wondering if that day could be moved, just simply because he has other things that he plans to do with his gyro day. Also, 3:40 is a little bit late in the day for him, given that he starts drinking at about 8. He's concerned that he'll miss that appointment because he might be a little bit too drunk. He's also concerned that he may not remember, and he says, given that it's his mental health, he's a bit worried about waiting that long as well. So I'm just wondering, are there any ways we can alleviate some of those concerns for him?
Sure. So taking on board some of those considerations, so it's really quite important to bear in mind to try and engage somebody who may have substance or alcohol addictions, that sort of timing it to the appropriate time. So late morning and early afternoon is often the best time to try and engage somebody. And often there is going to be multiple health needs, and so a longer appointment would be worth considering. As Sharon was mentioning, if somebody is receiving their benefits on a certain day, then that's really going to impact the level of engagement that they have on that day, but also likely to impact the following day as well. So it's having a bit of an awareness of that impact and trying to tailor it around that. An important thing to note is linking appointments, which I think a lot of people do already, but it's just really to stress home that if you're trying to reduce the amounts of times of having to come to the surgery, linking it in with the same day having the GP review as well as the nurse review, as well as having that continuation of care, which is really important for this group. So to reduce sort of recurrent traumas, sort of revisiting, it's really useful to have the same GP to continue going through this, the story and the life events. In terms of checking for demographics, it may well be that somebody has moved hostels or are now living in a new location, and so they won't be having access to receiving the mail where they had originally placed their address as. Important to check that they have a phone, and if they don't have a phone, then offering a sort of an appointment card so that something is in writing, or alternately checking that they have a support worker. If they have a support worker, giving them some form of alerting system, so an appointment card for their support worker to assist them to getting to the appointments as well will certainly help through that.
Thank you, Jasmin. So we're in the waiting area, and when people get bored, they can become quite challenging. But I want to just talk us through some of the challenging behaviours that you might want to consider that may present from some of the people experiencing homelessness accessing your service. So right at the top there, the very top two, very relevant for today's situation with COVID: inappropriate touching and spitting. Nobody wants to be touched at this point in time without solicitation. So absolutely, but more than that, many people think inappropriate touching is if somebody comes over and tries to grab your backside, but if they're standing around grabbing their own backside, this is also fairly inappropriate, so just bear that in mind. Repetitive behaviours, loud or aggressive sounding conversations. If somebody's had a couple of drinks, they may get quite loud. Sometimes it's the aggressive comes from a culture thing, where I know for a fact some cultures sound very aggressive and they're really not. They're just having a general chit chat. Under the influence of substances, that in itself presents many challenges. Crying or displaying extreme emotions. Yeah, just that really. There's not a lot to say on that. It can happen. Bad smells and poor hygiene. This is probably the one that you're going to come up against most. And when I say bad smells, I'm thinking unmanaged wound care. But one of the big things to really consider, one of the most challenging things you may find in your waiting area, is other people's attitudes and reactions to your patient who's experiencing homelessness. So yeah, it's important to recognise that that person may be experiencing quite a lot of prejudice in that moment. But it's also important, of course, that we think about how we protect all your other patients from any behaviours that are challenging coming from that client. And when I talk about challenging behaviours, I find it funny because most people think immediately to danger and threatening acts and risk. And as much as there is the possibility of those behaviours, I think they're the minor possibility. And I think some of the behaviours I discussed on the last page are more prevalent. I think we just need to manage with care and consideration how we help and support people to manage that waiting time. And the best way to manage people is, firstly, I know it was said in webinar 1, which if you missed, I strongly advise you catch up with, because it was really, really good. But there's the whole thing of not getting emotional. So managing your own emotions around other people's challenging behaviours. If somebody's becoming challenging and you become emotional, you have the potential to become as challenging. So part of it is about listening, hear what's being said, try to understand where that person's coming from and validate those experiences, because that person experiencing homelessness is experiencing something quite traumatic, and having a non-judgmental approach, which I'm sure you'll do. So, poor Alf, he's very disappointed. So this is a world where we haven't, unfortunately, had the very good advice from Dr. Malik. So he's had to wait the 9 days, and after waiting those 9 days to be seen, he's done his real best not to drink too much before coming in to see the doctor. However, at the last minute on leaving, he realised he had lost his Oyster card, which means he's had to walk, and he's walked 2.5 miles to come and see you today, but it's made him 25 minutes late. So there are a number of reasons, aside of losing an Oyster card, why someone might miss or be late for their appointment. So having no money for travel, other appointments coinciding, no phone for an alarm. If I didn't have an alarm, I wouldn't get up in the morning. It's as simple as that. Poor memory, or not having a reminder of the appointment. A fear of the appointment, like I mentioned earlier, not really wanting to know the outcome. Fear of societal judgment, fear of the waiting room really. Limited literacy or language barriers. The support system fails. So let's say they were due to have a peer advocate from Groundswell come out and support them, but due to sickness or for some other reason, that advocate hasn't been able to go out and support them. Poor mobility, a disinterest in their own personal well-being. Hunger / food venue times. Maybe they're hungry and they want to go off and get that free breakfast down at the day centre. And other conflicting priorities, such as alcohol, substances, benefits, housing. I could go on. So, final few questions from you, Jasmin. So is there anything the surgery can do to assist Alf today, given that he's now 25 minutes late? He's in quite a state, and I think he would appreciate any support you can offer him. Is it likely he's going to see a doctor? And what can we do? What support can be offered for future appointments?
Thanks, Sharon. So as I was mentioning on there, it's quite important to think about having an alert on the system. So as soon as somebody is mentioning their name, the alert system identifies to the receptionist that this patient may be homeless. So having some certain sort of training around that, sort of to being able to deal with the situation slightly differently. So in terms of what we do in the surgery that I'm at, which granted it is a surgery specifically for the homeless, however, how you can take this away for mainstream may be that acknowledging the fact that Alf has actually had to walk for the past 25 minutes and has really become late because of that and the various events that have taken place. What we usually do is sort of provide an emergency form, so people can complete the emergency form and sort of highlighting what they really need requiring and addressing on that day, and then that can be taken through to the duty GP, who then can see where he can slot them in, or if it's necessary to being able to see them at the end of the surgery. Just to point out, if you are rescheduling, then considering just a bridging script, because it may well be that they've been out of medication already for a few days, and it may well be that they've got their mental health medication that they require quite urgently. So a bridging script to sort of bridge that gap between the next time that they're being seen. Also to sort of suggest as well, if you are rescheduling, sometimes people are presenting because they really require that medical sick note. Now, in terms of how they may be presenting, maybe that it really sort of is passed to you as the receptionist to say that, you know, if I don't get this now, I'm not going to be paid, and I'm going to then X, Y, and Z will happen. So you can reassure them saying that, you know, it's been noted that you're here, that you've attended, that you're a bit late, and it's noted when you made this appointment. So when you speak with the GP, don't worry, anything that can be backdated will be backdated to this time of that discussion. The other aspect of this is to care navigation. So identifying some people may not well be linked to any services, and services such as Groundswell or other volunteer organisations would really benefit people if you can link them in there and then. And in terms of this delay, obviously there is a risk in terms of their mental health deteriorating further. And it may well be in your local area that you have certain services that you may well be able to signpost them to, and other things as well. So local services with physiotherapy or the community pharmacist as well, just to keep those things in mind and to providing that further. So when they get to see the GP and coming through to see the GP and the nurse. Now, I'm following on from the webinar 1, which really sort of gave a good idea of what the background, why it's important to take a person-centered approach. It really sort of helps really focus down on the needs and really helps with engagement. So if you're starting from where they are, it really changes that way to people coming back and reviewing things. Often, if this is the first time that you've seen this patient, you could be overwhelmed from the multitude of health needs, and they may well be just in their 40s, and yet they're presenting with early onset frailty and aging and have multiple health needs that need addressing. So trying to take a step back from that overwhelming presentation and really taking a view from, as I said, starting from where they are and working with their own priorities and developing a trusting relationship so you can engage them to coming back. It's a sort of, I would suggest that on the day that they're presenting, so you address their current health needs, have in the back of your mind where you are going to address in terms of the chronic conditions and how to sort of also look at preventative measures as well. So if this is the first time that you're seeing someone and they're coming in to have their blood tests done, considering the potential of a bloodborne virus screen as well, bearing in mind if there's a history of at-risk behaviours. Timing of medications is also quite key. So if it's something that you can combine so that they're having medications taken in one go, then that helps with compliance. And also bearing in mind that people who may be rough sleeping may well be exposed and sleeping in areas, or in the past sleeping on buses, where they're at risk of having their belongings stolen. And that could include their medication and at times obviously controlled drugs in that medication as well. So there's a significant risk around this. One of the ways around it could well be that you are considering daily collections of prescriptions from pharmacists, or giving just weekly scripts that they collect and pick up. The other aspect is to consider doset boxes. It can be very helpful for people who are in hostels, and that helps with them to remembering their medication, but also for their key workers to help prompting if that is needed to help in taking medication. I've said here about time appropriate referrals because obviously going back through to the other page where it sort of looks at that whole host of different physical and mental health issues, it's quite overwhelming for the patient if you're saying that you need to be referred to this and this service where they don't have the support systems in place to assisting them to get there. So really what I'd be suggesting here is like looking and taking into consideration what is the most urgent referral that's needing to be done at that time. Bearing in mind also that if you are referring on to psychological services and supports, people who may be on the streets are particularly may well be in sort of survival mode, and revisiting traumas from the past and sort of going through that psychological therapy is a trauma in itself, and it can bring up certain patterns of behaviours. So it's timing it so it's an appropriate referral. And also in respect to substance misuse and alcohol services. So if you are going to be making a referral to these services, it's exploring whether or not the individual is ready to work with them. And if they're not, then thinking about the harm reduction that could be put in place beforehand. In terms of follow-up, it's actually using the time that somebody requires a repeat medical sick note is actually key to engagement. And it's really important to bear in mind that you're going to be able to capture a lot of sort of opportunities to deal with the various health matters if you time it according to when that note is required for renewal. In terms of, as again previously said, so support workers, making sure that they are on board and that they can assist people getting to the follow-up appointments, and also gaining consent to being able to discuss matters with hostel key workers or substance misuse key workers and the various different services to try and get things and matters of concerns from their perspective, so that you're taking a bit more of a holistic approach to things. Bearing in mind that in terms of housing and social needs, having a support letter from the GP really does help, and sort of getting up that ladder really. So bearing in mind having that sort of available for them as well. What we hold in our practice is food vouchers. So I think food bank vouchers are really quite an important thing as well to bear in mind, that it would be useful to hand out if you can. Okay. So I'm just going to use an opportunity just to quickly, briefly sort of mention about wound care. We're hoping to get a few series of physical health matters addressed in successive webinars going forward. However, just for today, I just wanted to discuss this for a few moments. In terms of what struck me really over the past 5 years of practicing in this area is that there's very, very little provision in place for the homeless to managing such things as managing their wounds. And in some individuals, there's actually people who've been experiencing wounds and chronic wounds for over 20 years. It's a real point to sort of stress how somebody living with this day in, day out, and being in a situation where they're unable to access healthcare to managing and sort of dealing with this, but also their own personal hygiene, they're not able to manage it, how excluded from society they can feel, especially as Sharon was mentioning in terms of that bad smells and sort of that engagement, which it's been seen with the impact in sort of the waiting areas. One of them, a few quotes from one of the studies from Dr. Jamel Garrity, it says here that, for example, Sunday, the leg was smelling. By Monday, Tuesday, it would be smelling and dripping. Wednesday, Thursday, Friday, it would be stinking and dripping. Understanding it right in terms of that chronic picture of wound care, you know, there's so many different factors which really add to it, be it patient-related factors, wound-specific factors, the healthcare that's dealing with it, and the limited services. And really, I hope that you're able to join us on the future webinars in terms of being able to address this further. Going now to expanding on what was discussed in webinar 1 with regards to COVID-19 and the homelessness. And in summary, again, what they discussed there was about the recommendations due to the vulnerability and the need to social distancing, and how people who are rough sleeping and those in shared accommodation have now been moved into facilities and hotels to help them with that ability to self-isolate. They also touched upon there in that webinar about the vulnerability in this cohort of people and the requirement of the shielding, and that actually 30 to 40% of this population do fall into that category and will require ongoing shielding. Today, I'm going to sort of be a bit more specific on terms of the new general practice standard operating procedures and the guidance, which again, the link is available here. You can certainly search it through here as well. So in terms of what they've identified here, they've identified marginalised groups in the context of how we manage people with COVID-19. And they've really highlighted that how local authorities have been asked, been tasked with the providing of accommodation for rough sleepers, and meaning that those who are registered patients on your list may well be moved into different areas, and that you may well have new people who are sort of allocated into that, relocated into your area. And it's really a time to capture sort of those health needs for this new lot of people which may be coming into your area. In terms of what may be being done in your local area for trying to capture the health needs for this population group, it is worthwhile bearing in mind that there may be surveys or things linked in with public health that may be going on, trying to understand sort of the background and linking people into the services going forward. In London in particular, there is the CRISP survey, which is being rolled out and is really sort of used to try and map what's currently going on with healthcare needs and identifying the medical conditions and linking in from GP to other services as well. This survey in itself is available. I don't actually have the link of it yet, but that can be made available later if people are in the London area are willing to sort of get engaged and sort of involved in this survey. Certainly, it's important to bear in mind that the benefits of that survey in itself sort of highlight how we can really utilise the information that's captured and sort of help direct development of services going forward. So in terms of that, I really wanted to sort of say I'm going to go on to now safeguarding homelessness and rough sleeping and talk about an analysis of safeguarding adults review and how we can sort of come off what the efforts of which have been made in terms of COVID-19 and moving people into these facilities and engaging people who have not necessarily engaged with healthcare for possibly decades, and that vast amount of information of health needs which are coming to light. Looking at safeguarding reviews and looking at the sort of the analysis of this, it really sort of drums home where gaps are within this cohort of people. And in terms of this particular paper and the review, it outlined that in 2018, the Office for National Statistics collated published findings of numbers of homeless deaths in England and Wales and estimated that 597 deaths in 2007 occurred. And this was an increase of about 24% from the previous 5 years. It again identified, as we said before, the mean age of death being between 44 years for men and 42 years for women, and that compared to the average age of death for the general population being 76 years for men and 81 years for women as well. So these slides will be available once this webinar is over. So I'm not going to go through the in-depth detail which has gone through specifically 14 cases here and highlights various social care needs and safeguarding issues. I'm just going to focus down on one particular case, which really struck me because of the the communication between primary care and secondary care being a real concern. So this is adult A. He was a 45-year-old male, history of schizoaffective disorder and a history of being detained under the Mental Health Act, has a history background of chronic physical ill health, and the cause of his death was put down to natural causes to which neglect contributed. So in adult age discharge plans following his detention under the Mental Health Act, they were described to be woefully inadequate. He left hospital on a community treatment order without there being a check that he was registered with a GP, despite his mental health problems and diabetic needs. Local authority housing services did provide him with accommodation, the bed and breakfast, in which he shortly died following the discharge, but were not aware of the full dimensions of the risks posed to himself and to others, because the risk assessment supplied to them was a year out of date. There was a failure to assess his mental capacity regarding his decision-making in relation to his diabetes care and or his acceptance of the conditions of the community treatment order. This meant that the discharge plans, such as they were predicated on a decision that the trust did not know that adult A was able to carry out. So really, I mean, in terms of summarising this, it really sort of highlighted for me that there is a significant amount of concern around the safeguarding of and the well-being of these adults, and that in summary of the findings that was found was that there was a poor inter-authority cooperation, lack of lead agencies of professionals to coordinate the care, and disputes between authorities and lack of key people being involved in MDTs. As I said, the poor coordination of hospital discharge, as well as Housing Act assessments, there was a lack of appropriate assessments of vulnerabilities and needs. In terms of support, there was a lack of support accommodation provision. And one of the points that I really, again, wanted to stress home was the fact that self-neglect isn't really seen as a reason to make a safeguarding referral. However, in this review, it really highlights that often self-neglect should be triggering a safeguarding referral. Also to highlight about mental capacity assessments, and on the background of a fluctuating capacity, that really needs to be taken into consideration as well. So going back to the summary, I'm going to hand over to Sharon to just give us a bit of a summary now.
So knowing how everybody loves the tick box, just these, to summarise, these would be the questions I would be wanting to ask myself. Have I considered the best time of day for this patient? Does the patient need a double appointment? Is there any information that I can give them in the meanwhile? Anything I can do to make the experience easier? Have I taken details of their support worker? And do I know the best way to contact and remind them of this appointment? Have I addressed their concerns? Are there any allowances we can make for lateness, if they're late? Not everybody's late. Is the patient clear on what's going to happen next? And are there any communication barriers for this patient? Are there any other professionals that I need or could speak to? And do I have consent to speak with those professionals? And is there a safeguarding concern here?
Thanks, Sharon. So yeah, those are the questions really we'd be posing to suggest that you really sort of have a look at and consider how to help people going forward. We've got a list of different things for useful training resources here, and particularly at the top we've got there the link to Groundswell. So in terms of what could be available to assist you with people who may be homeless. And in terms of future events, that draws us to a close today. However, for future events, there is going to be the webinar 3, which is on safe surgeries, and that's going to be on the 18th of June at midday. And it's presented by Doctors of the World, who will be giving us this discussion and introduction to the Safer Surgeries Initiative and improving understanding of migrant entitlements to NHS care. They'll use case studies and interactive exercises as well to explore the health needs and entitlements of migrants in vulnerable circumstances and people experiencing homelessness. The link to the webinar is available here, and I think that you'll be able to click on that once we've finished. So yeah, and I think that brings us to a close. So is there anybody who has any questions?
Thanks, Jasmin. Thanks, Sharon. It's been a fascinating hour. We've got quite a lot to get through, bits of feedback and some good questions from delegates. So I'll rattle through a few bits. I think, as Christine put in the chat, the health needs assessment link is in there, so please do have a look at that, delegates. And also, I think Christine put up the link to the standard operating procedure for wound care as well, so please do look at that. We had a bit of feedback from, I'm going to go to my other document, Jane Morton. Sorry, Jane, I'm not sure where you're joining us from, but give us a bit of feedback about wound care, saying that we provide daily clinics from an outreach vehicle, plus in-reach in hostels to support wound care, using a variety of measures, including self-management, peer support and engagement incentives, usually a hot drink and biscuits and clean socks. So, you know, simple but effective. A bit of feedback for you, Sharon, from Simsal, who near the start was commenting, saying it was a great way of articulating the issues and the ask going forward. Very powerful, so a bit of a nod to yourself. And Caroline Shulman has joined us. Good afternoon, Caroline. And you'll all see in the chat box there's an ask and some information from Caroline about the CRISP survey. So if you are interested and able to help, have a look through there. And I think it's by email to Dr. Binta Sultan, and she can discuss how you can help us all out there. Kerry Ahern has just come in. Could the wound care person please give contact details? The wound care person, are we talking about our commenter who was Jane Morton? I think you're probably talking about, Kerry. I think if you're both still in the chat box, we can do that. We are. Excellent. Okay, if you don't succeed via the chat in the group, I will facilitate that afterwards, see if I can link the two of you up. Been something of a debate, presenters, that have been going on. Again, this is all in the chat, so I'll have to kind of précis a little, but it was a question from Catherine O'Byrne. This was regarding possible GP blacklisting. Does this exist? How does it work? There's a couple of questions and answers here, so bear with me. Does it exist? How does it work? Are people denied access to the GP because of challenging behaviour? Is it just the GP or all of primary care? She'd heard there some people have been advised to phone a special NHS England number to get, but she was unclear on that. Kerry Ahern, thank you. Kerry came back and was saying this is the violent patient scheme and the service for usually for people who've had assaulted staff. And again, sorry, I'm speeding through this. And Catherine said that's the one she thinks it is. And Ruth commented, Ruth Hall, saying it's now called the Special Allocation Scheme. There's a bit of a garble there, presenters, but any feedback, any knowledge on that, or should we come back to that later?
Yeah, so in terms of the special allocation service, that is something that I think there's certain places that it's available and certain places that it's not necessarily available, and then access that is possibly difficult. So again, if there is a specialist homeless service in your area, it may well be that if you do find that they are having challenging presentations, that it may well be better that referring them onto a service which is specifically designed for that. And if you are taking off somebody off the list because of particular types of behavioural patterns, then finding out whether or not there is an SAS service which is available to take people on would be beneficial as well.
Great stuff, thank you. Question from, hope I get my pronunciations right, Cesar Domac. I'm interested to know if there is no MDT or corroboration between the agencies, who is taking the lead to address the lack of collaboration as a way forward? Is that something we can pick up on, or is that one to come back on, do we think?
Well, for sure. I mean, I think from a position as a GP, I'd be saying that if this is the case, that there's no particular MDT set up in your area, maybe sort of using as a case review and sort of evolving, sort of getting people involved from the drug service. They may have an alcohol or drug service key worker. So linking in those basic services so that you can have that discussion and a case review per person and individual. And it may well be, if you do have a high proportion of people who are homeless in a certain area, then looking to put that in place. Often it's associated with, sort of repeat attenders in A&E, and it may well be that you can tie in services with regards to how to deal and manage people who attend in A&E frequent attenders.
Brilliant, thank you. And looks like we're getting near time. Thank you from Caesar there. So a little bit of feedback from Alex Skirton. So it's a great presentation. Housing Solutions at Southwark Council are encouraging all GPs to use the duty to refer form, which can be found Googling duty to refer. So that when referring patients threatened with homelessness to our service. Sorry, I've garbled that a bit. I think this may be just a reflection that's coming from Alex as opposed to a question. So good to see that bit of shared experience. And a thank you from Alex. So I think I must have done the job there as well. I just wanted to round off. Oh no, we have more questions, so we're still going. Elaine Woodward's not letting us off the hook here. Thank you, Elaine. It says NHS England are funding a number of CCGs every year to develop RSMH services. Haringey and Lambeth received 5 years funding in 2019. So again, I'm getting some nods there, Sharon. So that's obviously something we're aware of. So again, good bit of shared experience there, I think. Okay, we'll better start wrapping up because we're getting near the hour. I did want to ask you both before I let you go, if there was one takeaway you wanted to give delegates before we round off, what would be the one tip, the one thought, the one thing that they might want to go and do? Sharon, maybe come to you first.
Sure, no problem. I suppose, I mean, it always comes back to the same thing, which is treat the person in front of you as if they were a beloved family member.
Excellent. Thank you, Sharon. And Jasmin?
I'd say that this is an opportunity. I mean, COVID has been pretty traumatic for everybody, and it's certainly put us in a position where, you know, sort of we're in a very different world. But it really has been an opportunity to get people, you know, sort of back into healthcare, those who have been homeless. And it may well be that it's been decades. So I'd say that making sure that the list, that you're open to being able to register people and looking at sort of those health needs assessments and trying to tackle those and linking people into the services. That's a
brilliant. Thank you. And thank you both once again for a fantastic session. So thank you, Dr. Jasmin Malik. Thank you, Sharon Clint from Groundswell. I've been James.
Thank you,
Thornton. Thank you for joining us at Healthy London Partnership. Do register for next Thursday's Safe Surgeries webinar. That's 12 till 1. And I will bid you all a happy afternoon. Thank you.
Thank you,
James.
Thanks, James.